So let's start today, everybody. Good afternoon, everybody. Happy you can all make it. It means at least you get a little bit of a break in work, or you got a day off, which is even better. Let's get this going. There we go. So today we are talking. I'm going to put this up here. I actually don't know if you guys can see this or not. That's what you said. So we're going to be talking about spotting subtleties on our hematology exam. So hematology is one, obviously, of the blood tests that we very commonly do in practice on a daily basis. It gives us an overview of the red blood cells, their indices, which we're going to talk through a little bit. We're going to talk a little bit about patterns with the white blood cells and what we should consider when they go high or low. And we'll talk a little tiny bit at the end about the platelets. Obviously, take into account, this is a quick overview. This is not the end all and be all of hematology, which is incredibly interesting. So when we get the results of our hematology analyzer, be it in-house lab or external lab, we get a number of, well, a series of numbers really. Now, what's worth to know is that obviously the red blood cell mass be measured by hematocrit, red blood cell count, or hemoglobin. I'm often quite lazy with my cases, and I mainly will look at the hematocrit, but the other ones might be relevant as well. Now, what's worth to know from the start is that the machine will measure, I think most machines do this, but the red blood cell count, it will measure the hemoglobin and it will measure the mean corpuscular volume of your red blood cells. So how big are these cells? So we're talking normal size cells, smaller, larger cells. Now it gives you a mean, so that means an average. So if you got a few that are smaller, you might not pick that up, or a few that are larger. So you need the average to go up, really. Now, the rest of the values, including the hematocrit, are calculated values of your red blood cell indices. Now, I haven't included your nucleated red blood cells because it will measure those and your retic count. Okay. So it's worth to remember that your hematocrit is a calculated value and it calculates it through multiplying your hemoglobin and your mean corpuscular volume. So if either one of these will go up, and we'll talk about that in a minute, your hematocrit might be falsely elevated as well. Now, the one measurement we often take in the clinic as well is a PCV, so a packed cell volume, which is in your micro hematocrit tubes, which is easy to do. Trick is to spin it down for long enough, otherwise there'll be more plasma trapped and it might be slightly higher than what it truly is. So let's talk about red blood cells and what they normally do. So the main function of our red blood cells is to carry oxygen around in the body. And they do that by binding to the hemoglobin in the red blood cells. Now we have a normal steady state. So red blood cells do not live forever, even in a healthy body. In dogs, I mean, there's a bit of variation, but we would generally, I would go by, in dogs, a red blood cell lives for about 100 days before it dies of old age, if you think of it that way. In cats, it's slightly lower. It's about 70 days. So think about it, maybe 2 and a bit months. And interestingly, and sighthounds are going to come back to different bits here when we're talking about hematology, but sighthounds' lifespan of red blood cells is lower as well, is about 2 months. Okay. So, but we know that for an individual patient, they, throughout their healthy life, once they reach adulthood until they get into their senior life, you will have a normal red blood cell count that is normal for that patient. If you remember, if you look at the variation of the red blood cell count here, say in dogs and in cats, there's a fairly wide variation. Now, it's worth to remember that that is the population variation. That is not necessarily the individual variation. For an individual patient, your settings, your body-owned settings are pretty standardized. I'm not going to say they're absolutely the same, but it's not going to have such a wide variation in a normal situation. Okay, so if you're ever taking any bloods of that patient, be it a pre-anesthetic blood sample, in a healthy situation or a health check or whatever you did, but you have something there to compare it with. Obviously, be careful to compare it with a blood sample that was taken in a diseased patient anyway. But if you've got a baseline for that patient, that might help you to compare it with. Okay. So your red blood cells get produced in your bone marrow, and what you need to produce red blood cells is a healthy bone marrow. And you will also need erythropoietin, which is produced in your kidneys, and iron as a building block. So what happens is your kidneys produce erythropoietin, that will go through the blood to the bone marrow, which will stimulate red blood cell production. And there is a normal turnover here, but you need all these things in place for there to be a normal red blood cell production. Okay. So when we then look at physiological variations, I've put a few things on here. So we said with normal dogs, that's a general baseline that will come on your reference ranges. They're normal adult dogs. Average breed is what you get. As with any reference range, about 5% of the patients will fall out of that normal reference range and will still be their normal. So take that into consideration, but often they're not very far outliers. But some dogs might have a slightly different values. And these reference ranges, they vary from analyzer to analyzer. So things there to consider. Now, in newborn animals have very much the same value as their parents, but then that's going to start dropping. So till they then reach adulthood, and that's a bit variable from dog to dog and from the kittens, but say 6 to 12 months. So between 2 to 6 to 12 months, they can have a hematocrit that is slightly lower than what you would expect an adult dog to have. So it can be high 20s, low 30s. Okay. Now, these dogs as well try and compensate by that and have a slightly higher reticulocyte percentage and count. So it is worth knowing that. Otherwise, if you get an 8-month-old dog in with a hematocrit, for whatever reason you've taken it, of 28%, and there's an increased reticulocyte count, you might be believing that the dog has a clinical anemia. Now, if the dog's clinical, that is slightly different. But take into mind that that could be normal for a younger dog. And they might have a slightly higher mean corpuscle volume than when they become an adult, but that will probably still be within the reference range. Now, as dogs go past their adult age and go into the senior age, again, that hematocrit can slightly drop over time as they get older. And their mean corpuscle volume might slightly drop as well. Again, that doesn't mean that it will be below the reference range, but if you were to compare it with a previous sample of that dog a few years ago, that's what you might notice. Now, one group of dogs that we all probably see in our clinics is the sighthounds. And sighthounds, again, once they are mature, so not as a puppy, but once they reach 9, 10 months and older, they will often have a higher hematocrit than the average dog population. And we all know that it's 50, 65%. And after a dog race, that could go up for a couple of hours by splenic contraction, even slightly further. Okay, but that should drop down again. So they will have a higher red blood cell mass anyway. What we do know, as we said, their red blood cells don't live as long as those of an average dog. They have slightly larger red blood cells, and the hemoglobin concentration will be slightly higher as well. And then one other group of dogs can be affected by what we call macrocytosis. These are the toy and miniature poodles, which might have a slightly lower red blood cell count, but a larger than average red blood cell size. Okay. So then go to the next slide. The two other things that could affect your measurements is lipemia. So if your dog is not starved and your sample is quite lipemic, it could give you a slight elevation of your hematocrit above what is the right value for that dog and a slight increase in your hemoglobin. If your blood is stored for longer than 24 hours, and probably that is something that gradually happens, but you will get some red blood cell swelling, which will increase your MCV. And as we said, because your hematocrit is a calculated value, it will increase that in turn as well slightly. Okay, let's go back to anemia. So we'll talk first about anemia. We'll then talk briefly about erythrocytosis. So anemia being a low red blood cell count, erythrocytosis being a high red blood cell count. Okay, so let's talk anemia. Last week, we spoke specifically about IMHA, and we spoke a little bit about the baseline of anemia. So just for the people that weren't here, but let's recap that. So anemia is a reduction in your red blood cell mass. And when we want to consider what's going on, there's a few things we want to look at. We want to look at, is this acute versus chronic? And that often comes from the history, how long have the signs been there, how good is the dog coping, other things. Or you could have taken some bloods already before and you know it's more chronic. Acute severe anemia or marked anemia, dogs will struggle with an awful lot more than and cats as well, than on a chronic level. It's not unusual for us to see a cat walk into the clinic with a hematocrit or PCV of 10, 11%, and it is still very much going around its own business. It might not be 100% running around at home, but it can cope with daily life pretty well because it's been chronically adapting to a slightly reducing red blood cell count. If a dog bleeds or becomes with an IMHA, even without obviously the hypovolemia, anemic and the anemia drops, say, from 30 to 15%, that dog will struggle an awful lot more than the cat with 10% and chronic anemia. Okay, so we want to differentiate acute versus chronic. We would like to differentiate, which we're going to do in a minute, regenerative versus non-regenerative. And then we want to have a look at how severe this anemia is. And I've put some line figures, obviously, compared with a normal reference range in that table. Now, again, word to remember, in a sight hound where you start off with maybe a normal value of 55 or 60, 30% hematocrit is already a moderate anemia. Okay, so it will drop quicker, and think about what is the percentage of their normal expected, if you know their normal value or their normal expected value to be in where you're going to classify this. But a reduction in the oxygen carrying capacity of your red blood cells will lead to weakness. And if it is severe, you're going to notice that the body is not coping very well. And that is the point when we start thinking, should we transfuse this dog? When people ask us, when do we transfuse a dog? Definitely with IMHA, it all depends on how the dog is coping, what we expect that hematocrit to do in the future. Are they already regenerating or not? To say dogs that are not coping because they don't have enough oxygen to go around, you will notice that their heart rate will go up because they're going to start to pump those blood cells around twice as many times a minute to try and get more oxygen around in the body, and they're going to be breathing faster as well. So, as with anything, when I consider why are things low, the measurement of the red blood cell mass is low. Why is it low? Well, you're either three groups of patients, you're either not producing it, your bone marrow is not functioning properly, in which case you're going to get a non-regenerative anemia. Okay. That might be because they're not coming out of the bone marrow, but the issue is within your bone marrow. You're going to have a regenerative anemia if you either have, or you should have a regenerative anemia if your bone marrow is functioning fine and if you have blood loss or hemolysis. So I've put pre-regenerative on here because what happens, so when you become hypoxic, you become moderately to markedly anemic, your oxygen carrying capacity reduces, we said, your kidneys will get a reduced oxygen content in the arterial blood, and certain cells within your kidneys will produce erythropoietin. So with the reduced oxygen content traveling through the blood, this production should be going up with everything functioning normally. So you get an increased erythropoietin level, which will take it to your bone marrow, and that will stimulate your red blood cell line to produce more blood cells. Now, there's a little bit of a lag phase there from the production, the release of erythropoietin to the stimulation of the bone marrow, who needs to stimulate those earlier precursor cells more to start producing and dividing to produce more red blood cells, or initially reticulocytes, and to kick that out in the blood. Now, in an increased demand, your reticulocytes will be increased in your blood, but that will take a few days before that's going to be visible. Okay, so you will have what we call a pre-regenerative phase, which is a couple of days before you're going to start seeing a reticulocyte count, and that can be up to 5 days. And your peak response, on average, will be 4 to 6 days after an acute anemia or an anemia. significantly developing. What you then want to look is how good is that regenerative response? And again, I've put some numbers there to give you an idea. But if you have a severe anemia, once you reach your peak of your response, you should have a marked response there as well, because it could still be inappropriate. There might be some response and some increase of reticulocyte, but depending on what the body should be doing, that might still be inappropriate. So if we have regenerative anemia, we get an increased reticulocyte numbers in the blood, and the reticulocytes, they are slightly larger. So let me see if I can show you guys. So this is a reticulocyte, slightly larger and slightly bluer than a mature red blood cell, what you can see, okay? So when you look at a blood smear, if you can detect a fair proportion of these, you know that there is a regenerative response going on, even if you're still waiting for your blood results. So anisocytosis, which means the variation in red cell size, is there, and polychromasia means that there's a variation in red cell coloring that you can see. And both those are good indications that you have regeneration happening.
I have a question. Could maybe everybody mute themselves? Because there's a lot of background noise, especially Anna, maybe.
Sorry.
Thanks a lot.
I can't hear anybody, but thank you for mentioning that. As we said, you require a normal bone marrow to do this. Sorry, do you want me to see if I can mute everybody?
I think it's fine now. Anna muted herself, so I think we should be fine. Thanks a lot.
Let's go back one slide. So regenerative anemia, generally, we're going to see after a few days if you have a bleed or if you get destruction, either immune-mediated or non-immune-mediated destruction of your red blood cells, that then causes the drop in your red blood cell mass and your relative hypoxia. Let's go to non-regenerative anemia. And there's a few groups here that we all will classify under non-regenerative anemia. So as a baseline, we said normal production of red blood cells requires a normal bone marrow. So if that's deficient, that might not work. Yeah. We require erythropoietin. So if that's not happening, that red blood cell production won't be normal either. We have some other endocrine diseases that influence that bone marrow production as well. And we need iron as a building block. So if we don't have enough iron, we're going to start seeing changes as well that could lead to non-regenerative anemia, okay? And then there's anemia of chronic disease, which is probably a relative iron restriction and other issues there, depending on what the cause is. So if we're talking a reduction of erythropoietin, think about it, producing the kidneys. So if you get chronic kidney disease and destruction of a lot of your normal kidney tissue, then you might be starting to lag when you get in an advanced stage erythropoietin producing cells, and that's what leads to your anemia with your chronic kidney disease. With certain neoplasia, you can have the same effect, and definitely kidney neoplasia, lymphoma, carcinoma, we can definitely see destruction of those as well. Okay. When we talk about endocrine diseases, underactive thyroid will often lead to a slight non-regenerative anemia.
Sorry for
I can still hear somebody talk through.
Again. Yes, Cameron, can you please mute yourself? Thanks a lot.
Yeah. You should chair for me next time. That's a lot easier. And then if we get any anemia of chronic disease, we said iron deficient anemia. So when do we become iron deficient? And I think I've got a slide on that in a minute. But we are talking, we're either not absorbing the iron out of our food. We got extensive GI disease chronically. We're either losing iron, and that is generally chronic blood loss, which could be chronic hematuria. It could be chronic GI blood loss. Or systemic shunts are probably involved with this as well. And what we start to see is when you don't have enough iron in your blood to make the red blood cells, is that you're going to get smaller red blood cells. So you're going to get a reduced mean corpuscle volume. and hemoglobin content in your cells. So you get microcytic hypochromic anemia, but we'll overview that in a second. And then if you have a bone marrow issue, that is not going to be producing normally, is it? So if you get myeloptesis, you get neoplasia, and then the one unique feature, which we see a fair bit of, is precursor mediated IMHA. So where the immune mediated destruction is not directed at the red blood cells in your vessels, but it's directed at any of your precursor red blood cells. Okay. At which point your bone marrow, if you take a sample, you will see that you're trying to regenerate that red blood cell line, but at a certain stage that stops off, and there often is some phagocytosis of those red cells as well. So they don't make it to the stage of a reticulocyte count and into the bloodstream. So to just review the different patterns really that you're looking at. So you're looking at either, in all these patients are anemic, you're looking at a regenerative anemia, which normally should have an increase in cell volume. Okay. You might, if you get a strong regenerative response, you might get some nucleated red blood cells and you get an increased reticulocyte count. You get a non-regenerative anemia. All of these stay quite stable. They're pretty much normal, except obviously you're anemic and your reticulocyte count is low. Okay. And if you have an iron deficient anemia, you will have a smaller cell size and less hemoglobin, so that will drop. Again, that doesn't happen overnight. So as you lose iron, these things will gradually go down. So, and that is where sometimes doing a repeat blood sample a week to 2 weeks later, even just rather than just doing the PCV, might give you further indication that actually those values are dropping gradually. I am probably losing some iron somewhere. Okay. That was anemia as a brief outline. When we talk about an increased red blood cell count, we talk about polycythemia or erythrocytosis. Okay. So what can cause that? There's 4 groups in this that can cause it. I mean, one is your hematocrit and your PCV are percentages. So if you get dehydrated, or your patient got dehydrated, and your relative liquid or plasma drops, that same number of red blood cell will cause an increased hematocrit. Okay, so if you get dehydrated patients, that will bring it up depending on how severely dehydrated they are, which will mean if you get a normal value in a patient that comes in severely dehydrated, that by the time you rehydrate it, it probably will drop in a few percentages. So you might need to recheck this after rehydration if you have any concerns, or if you're already anemic, it could be a lot worse after anemia. Now, the one thing I will say here, and that people often will question me on the advice line, is should we put an anemic patient when it's dehydrated on fluids? And I will always say yes. So, yes, you will drop your hematocrit, but there's 2 things that will matter quite greatly. Yes, that number will drop, but your total red blood cell count, if you're not bleeding, will stay stable. Okay, so your oxygen carrying capacity from that point is the same. And as you're rehydrating your patient, your circulation will improve. And therefore, you will deliver more oxygen to your tissues with a lower hematocrit being rehydrated than with the slightly higher hematocrit but being dehydrated. So, as long as you don't think you're going to lose more red blood cells, that number, that hematocrit number will drop, but your oxygen delivery will improve. I hope that makes sense. I can't see if anybody's asking any questions, so please, I mean, if you do have any questions, either shout out and interrupt me, or we'll do it at the end. The other reasons could be, so in certain endocrinopathies in dogs and cats, we will see that there is an increase in hematocrit or PCV. In particular, that is cortisol in dogs. So cushingoid dogs will have a slight increase potentially of their hematocrit. It very rarely goes very high, but there will be a slight increase compared with what they had as a baseline. Hyperthyroid cats could get a slight increase as well. And acromegaly in cats, but not in dogs, will increase the red blood cell count. Okay. Once we go past these, we will then split it up into primary and secondary. And again, as you can see, there's quite a lot of things in here. This is a whole different lecture on its own. But primary meaning that the bone marrow cell line, the red cell line on its own is producing more red cells than the demand should be. Okay. And that will gradually increase. That is the polycythemia vera that can definitely go up to values that are going to be damaging to the body because you're going to get a hyperviscosity syndrome because of the high number of red blood cells. And that will need treatment. We then, on the other hand, talking about secondary, and they can still get such a high hematocrit or PCV, but secondary is because of an increase in erythropoietin. Now, that increase could be appropriate, and appropriate being there is hypoxia that triggers the erythropoietin production in the kidneys. So that could be either because you live high up in the mountains and there's less oxygen in the air. That could be because you have a chronic lung condition where the oxygen absorption isn't good, like pulmonary fibrosis in Westies. We sometimes see that. Or it could be that you got a cardiac condition, in particular, a right to left shunt, where you get poorly oxygenated blood to go around the body. Okay. It could be inappropriate. So the erythropoietin production is happening all by itself. There's not a low oxygen content, but those kidney cells are overproducing. And you could see that, sorry, and I said it earlier wrongly, you could see that in a renal lymphoma, renal carcinoma. There's some nasal tumors as well that can do it, and some other rare ones, but that's the inappropriate one. We're not going to talk about treatment of polycythemia because otherwise we'll be here the rest of the day. Okay, white blood cells. Let's go through these briefly. So when we look at our white blood cells, they obviously composed of your neutrophils, your lymphocytes, your monocytes, eosinophil, and basophils. As we said, in a minute, we'll talk about platelets. So the biggest part of your white blood cell count in your blood is attributed to neutrophils. Your neutrophil count is far higher than any other of the cell lines in a normal situation, both in dogs and in cats. They all get produced in the bone marrow, so you need a normal bone marrow to produce them, and they all take part in some part of your immune system. So when we look at the neutrophils, as we said, they're the more common white blood cells. They get produced in your bone marrow, and if you get earlier forms being set free because of an increased demand, you will start seeing these band neutrophils. If you see an increased band number in your blood compared and maybe the segmented, so you'll be talking about a left shift. And if your number of your band neutrophils takes over the number of the mature neutrophils, you're talking about a degenerative left shift versus the other one we call a regenerative left shift. The problem with the degenerative left shift means that your demand is so high that your bone marrow is kicking out a lot of neutrophils at an early stage, but your demand is so high that a lot of the mature ones, or even they don't make it mature, they get destroyed or used before they can get to that mature stage. So that is not a good situation to be in. If you've got more bands than mature neutrophils, that is generally a negative prognostic factor. You've got a severe issue going on here, okay? So, but generally a neutrophilia, even if it's mature, this can happen with any inflammation. So where we often see dogs being put on antibiotics, infection can cause a neutrophilia, but definitely immune-mediated disease can cause a neutrophilia. Sterile inflammation with neoplasia can cause a neutrophilia, and tissue necrosis can do. So it does not mean there is a misconception where people would say, my dog has a neutrophilia, therefore he needs antibiotics, there's an infection going on. He might have an infection, but that is far from certain. Okay. You will also get it in patients that are quite stressed. So you will get a stress leukogram, and I've put you the algorithms at the bottom of this anyway to talk through so we can compare those. Now, a neutropenia, remember from our anemia, we said low red blood cell count, we're either not producing, we are losing them, or we are breaking them down. Okay. Neutrophils are very similar. We're either not producing them, we are using them, or we're breaking them down. There is such a thing as immune-mediated neutropenia, but it's not very common. Okay. We can be using lots of them, and then the question is, well, do we have any bands there? because then generally, if you're using that many, that you're going to drop your neutrophil count soon. Maybe not in a peracute setting, but soon you should start seeing bands appearing. And if you have a decreased bone marrow production, which could be either drug related, could be virus related, or other infectious diseases related, you will then have a lower blood cell count as well. Now, if you get any infiltrative disease into your bone marrow, that will affect eventually all your cell lines. It's worth to know that your neutrophil line is generally going to be the first one that's going to be affected in your blood, because your lifespan of your neutrophil is the shortest of your white blood cells. Okay, unless you're going to start using them. But if it's purely because you're not producing them and you're not replacing the other ones, your neutrophil count will be the first one to drop generally. Your platelet count will be after that. Your red blood cell count, remember, red blood cells in dogs live 100 days. Red blood cells in cats live about 70 days. It's going to take a long time before that's going to cause a moderate to severe anemia. So if you have a moderate to severe anemia without a neutropenia or thrombocytopenia, that it's unlikely you got an infiltrative disease in the bone marrow. You could have precursor IMHA, you could have other things going on that affect just your red blood cell now, but it's less likely that it is a leukemia or an infiltrative neoplastic disease then. Now, neutrophil count below 1 gives you an increased risk for sepsis. So if you have a reason, say immune-mediated destruction or non-production, and it drops below 1, that then puts you at an increased risk that an infection could take place. And the most common site of infection secondary to neutropenia would be your intestinal flora. Okay, I mean, if you have a cut on a leg, a deep cut, or a UTI, that will be there as well. Or if you get kennel cough, that is more likely to become a problem if you're neutropenic than it would be in a healthy animal. But yeah, so the count below 1 gives you an increased risk for secondary infections. But if you look at the lymphocytes, the lymphocytes, they are produced in your bone marrow, but obviously they live in your lymph nodes, in your any of your lymphatic systems, so spleen, thymus in young dogs. But we will see that your lymphocyte count in your blood will come up with stress. So if you have a stressed animal, I mean, reminding again, animals that come to the vets, the vast majority of them are quite worried about it. You're going to see it in response to a vaccine, potentially after the vaccine, first few weeks, that could come up slightly. It will be slightly higher in younger dogs, potentially as well. And if you have a long-term antigenic stimulation, so with some of the chronic infectious diseases, you might see that. Now, if it comes to a certain level, and definitely if they are small lymphocyte or well-differentiated lymphocytes, you will want to differentiate this with a chronic leukemia. And we spoke about this a few weeks ago. You can do this either by flow cytometry or PAR. Okay. If you have a low lymphocyte count, that can happen secondary to corticosteroids. So, and I've caused a very big confusion here. Stress leukogram, sorry, will cause a lymphopenia. And Cushing's, iatrogenic or hyperadrenocorticism, will cause a low lymphocyte count as well. So I think my slide before, yeah, an inflammatory leukogram will cause lymphocytosis, not a stress leukogram. I'm sorry for that. Certain viral infections, parvo and distemper, are definitely known to cause lymphopenia. And then if you lose lymphocyte-rich fluids, be it an extensive chylothorax, PLE, etc., that will reduce potentially your lymphocyte count as well. But because you can see it in stress, and stress doesn't have to mean emotional stress, physical stress as well, it's very hard sometimes to interpret a slightly low lymphocyte count as anything significant. Monocytosis can be stress-induced and inflammation. And then we talk about the eosinophils and the basophils, that they definitely come in a fairly low number in a normal patient. So if they are increased, it's definitely worth to look at. Obviously, they increase with parasites, fungal diseases, and allergies or hypersensitivities. They can be increased. There are also certain paraneoplastic diseases, so with certain lymphomas, we can see them. And then we have certain breeds that are predisposed to what we call a hypereosinophilic problem, and very rarely you can get leukemia. Now, I have put Addison's on here because, and we'll talk through that in a minute, because in a stressed animal, again, physically stressed animal, you should see an eosinopenia because of your high cortisol almost. So if you get an animal where, and let me talk you through the algorithms that I've put up. So we spoke stress, what should happen in a normal body when you have emotional as a human or physical stress as an animal is you get an increase in cortisol. Now that increase in cortisol will cause a neutrophilia potentially, and will often cause a lymphopenia and eosinopenia. Okay. Same if you get a stressed animal or, sorry, an animal that lives in fear or is really scared, you might not get the eosinopenia, you'll get the lymphocytosis. Okay. If you get an animal that is very unwell and might be some of these patients come in collapsed, has a normal neutrophil count, which could be either normal because we're using that many and it's got sepsis, and that's absolutely plausible, but there's no bands present, which is already a bit weird, but you could still be in this peracute phase. So it might be something you have to recheck. But if you get a high eosinophil count, and if you get a lymphocytosis, then that always rings something that does this dog have enough cortisol to respond, which could be consistent with Addison's, or you're running out of cortisol production, or but that is something that in a unwell animal, having an eosinophil count in a collapsed animal while you have a normal neutrophil count is something that should flag or trigger that question, could this dog have Addison's? And about 10% of dogs with Addison's will not have electrolyte abnormalities. Okay, we have seen these present with hypoglycemia, we've seen these present with normal glycemia, we've seen these present with a low albumin, with chronic GI bleed. It is worth just flagging that pattern up. If you get inflammation, if you get peracute inflammation, your white blood cell count might drop because you're using more, and it takes a few hours for your bone marrow to start increasing this production and kicking those out. Okay. And then again, come back to the sight hounds, so your greyhounds and similar breeds, they have a slightly reduced neutrophil count. So their neutrophil count quite often can be around 2. And there's certain other dogs out there, as we said, that have a slightly reduced neutrophil count, and that might be very normal for them. Last bit of today, platelets. So platelets, as any red blood cell, as any blood cell, get produced in the bone marrow. They get produced from your megakaryocytes, and they often, in contrary to what people think, if you got an acute bleed, they might drop. If you got a more chronic or steady bleed, or shortly after the bleed, these dogs will often have an mild increase in platelet count in their blood. So other options why platelet counts could be decreased, and depending on the level and where you live and things there, what infectious diseases are around, it's definitely infectious diseases. We quite often in the UK, if there's severe thrombocytopenia, see immune-mediated thrombocytopenia, which could be primary versus secondary, or in the newer wording, non-associated versus associated. Or if they get shreds in either thrombi, DIC, microvascular diseases. Some neoplastics, so splenic hemangiosarcomas often will be shredding platelets. So those are all things to consider. The one breed to mention in here, I mean, sighthounds have a slightly reduction in platelet count, but not as low as the Cavalier King Charles will have generally as a breed. About half of the dogs will have a platelet count under 100. They do not have any bleeding tendencies, and these are often larger platelets. So that doesn't mean every dog in that breed, but definitely more than half will have a platelet count under 100. That is worth remembering. So if they're not bleeding, don't panic about it. Obviously, keep an eye on it. Make sure they don't have any petechiae, any ecchymosis, but this could well be normal for this breed. So as a general rule, when we look at platelet counts, a few things to remember. Platelet counts are often difficult to count for in a machine because depending how easy it was to take the blood and how good you mix it with EDTA, and if it wasn't a completely fresh sample, you might get some clots happening, even a large clot you can see in a tube, or smaller clots you cannot see in a tube, but that will stop the machine from counting these platelets. And to get an accurate platelet count, you'd have to send it to the lab to have a look at a blood smear, or you can have a look at a blood smear in-house as well, which is what we will often do if we want to have an idea here and now. As a general rule, we will be talking, when we talk about bleeding risk, anything under 30 as a count in general will be a risk for spontaneous bleeding. So where little blood vessels through senescence will slightly break down, they're reliant on the platelets to stop that tiny bleed. And if you don't have that happening, you will get petechiae and ecchymosis. Anything less than 60, and again, they're not rigid lines, will mean that your clotting is impaired. Not saying that would take a doctor's surgery with a platelet count of 90 if it's not a cavity, but it is still, that is a ballpark figure there, really. So if in doubt, if you don't trust your machine, then have a look at a blood smear. So what we do when we do a blood smear, I think everybody knows how to do a blood smear. So you smear it at an angle and you try and keep it on the side. What you want to look at, you want to have a look in the body, and we'll talk you through that in a minute. But the first thing I always do is have a look at the feathered edge to see if there's any platelet clumps available. If there are, then that will if there are, then that will stop those platelets from being counted, and you're gonna not be able to trust your machine. But if there's that high number, you probably have a reasonable number of platelets. Once you've done that, you go and look in the monolayer on your smear and at 100 times enlargement on your microscope. And if you look in the monolayer, you start counting how many platelets you have in an average field. So you count 10 fields, average it out. And if you multiply that with 15, then you would get a relative number of what your total count would be times 10 to the ninth. So a normal count would be about 12 to 15 platelets per high power field. Okay, sorry about the dog. So that is me for today. Just want to let you know, next week we're going to be talking about diagnosis of Cushing's disease, because that was a request, and I think that is quite a good topic, hopefully, to have a short talk about. And then we'll go from there. Is there
Hello,
anybody that has any questions?
hello.
Oh, yeah,
Can you hear me?
I can hear you.
Uh, I have a case I want to discuss with you.
Okay. Can we take that
Uh,
after the chat, maybe?
yes. What?
That all right? I'll happily stay on, but if we just see if anybody else has any questions, or is it about this topic for Sal?
About this topic.
It is about this topic. Yeah,
Yes.
okay, go ahead then.
I have a cat, 1 year old. It's male. Okay. He is anemic. I did biochemistry. Liver, kidneys are normal. But when I see the CBC report, there is anemia, thrombocytopenia, and neutropenia. Okay. And that time he was eating. I gave the injection iron, multivitamin, levotonics. He become good. When I stop, then he become like again like this one. Iron, hemoglobin, everything is going down. What could be the cause?
Oh, bless you. And did you say this is a cat or dog?
It's cat, 1 year old, male.
Sorry, say it again.
It's male,
Okay.
1 year old. I did parvo test negative. I did coronavirus negative. I did FIV, immunodeficiency virus negative. FELE, leukemia virus, also negative.
Okay. And this cat is well, and how low are these values?
Values I do not remember now, but it's going down.
Are they, and how is the captain himself?
Active. After the 4 days, I gave recovery here in the Qatar. It's multivitamins and iron and multivitamins all. Then he's starting eating today, from today.
Okay. But how low is how anemic is this patient and how, because I would say
It's
generally if you have a significant anemia, you've got a
mm,
significant neutropenia and a significant thrombocytopenia, you've got a pancytopenia, your problem will be in your bone marrow, which is a
in
hard
bone
one,
marrow.
isn't it? Because I think then you're talking we're taking a bone marrow biopsy. The bit I'm not familiar with what infectious diseases you got over there, but I'm
Mm,
sure there's some that will affect the bone marrow besides FELV, FIV.
mm,
I can have a look at that for you. But I think your problem is gonna, it's very unlikely they're all three gonna be immune mediated. So your common
maybe.
denominator is either you got an infiltrative disease, your bone marrow, you get pancytopenia because you're running out of bone marrow, but then it wouldn't have improved with the medication that you've given it. Um,
Mm,
or you got neoplastic disease really going on. But again, that shouldn't have improved with what you're giving it. And this is a normally fed animal. Is it a normal commercial cat food or?
yes, yes, it's normal. It's
So
Royal
again, you don't
Canin.
think there's any nutritional before all this? There was no nutritional issues?
No, no,
Would
they
you
are
mind
always,
sending me the
always.
blood results and I can have a look at
Yes,
them? If you
yes, I
send
will
it to
send
the
you the
info
person.
email,
Yes, I will send you personal.
yeah, if you send it to the info email, it's probably easier to have a look at and then we'll go from there.
Yes, yes, sure.
Okay, amazing.
Thank you. Thank you.
Anybody else has any questions? No. Okay. Well, I hope you all enjoyed this,
Yes,
and then
thank you.
hopefully we'll see lots of you next week. If there's
Yes.
anybody else who joined halfway through, drop me a line, either on LinkedIn or via email, and I can send you the recording once we got it sorted.
Oh,
Okay.
Thank you very
Nice
much.
afternoon, everybody. Bye.
Thank you. Bye-bye.
You're welcome. Bye.
bye bye.